Hi all, I am Dr.Shaini Vaid, here to present the topic Cervicogenic headache. Let's start the topic. As the topic itself says, its introduction, cervicogenic headache. Cervico means related to cervical spine, its bony component, disc or soft tissue structures. Genic means forming or producing, hence it is secondary headache. This introduction is given by International Headache Society 2013. This is most common type of secondary headache, often underdiagnosed and untreated. It's causing health burden and major disability worldwide. The diagnostic criteria relates to a headache with cervical disorder or lesion associated. Headache which is improved or resolved in parallel with improvement in or resolution of cervical disorder and lesion. In this, cervical range of motion is decreased and headache increased by provocative measures. Headache decreased with diagnostic blockade of cervical spine structures and nerve supply. Clinically relevant anatomy. You can go through all the structures, joints, involved muscles, ligaments, its nerve supply. You can get into detail of it. I'm not explaining it here. Pathophysiology. The C1, C2, C3 nerves relay pain signals to the nociceptive nucleus of the head and neck, the trigeminal-cervical nucleus. This connection is thought to be the cause for referred pain to the occiput or eyes. Aseptic inflammation and neurotransmission within the C fibers that is caused by cervical disc pathology is thought to produce and worsen the pain in a cervicogenic headache. The trigeminal-cervical nucleus receives afferents from the trigeminal nerve as well as the upper three cervical nerves. Neck trauma, whiplash, strain, or chronic spasm of the scalp, neck, or shoulder muscles can increase the sensitivity of the area, which is similar to the allodynia that is seen in late chronic migraine. A lower pain threshold makes patients more susceptible to more severe pain. For this reason, early diagnosis and therapeutic intervention is important. Epidemiology. It is chronic headache and its severity belongs to moderate to severe. The pain symptoms can be. It is episodic. Most common age affected is 30 to 44 years. And it affects men to women equally. That is, the ratio is female is to male. It's given 50-50. Pericranial muscle tenderness on the painful side. Then comes the etiology. Referred pain arises from irritation by cervical structures innervated by spinal nerves C1, C2 and C3. Therefore, any structure innervated by C1, C2 and C3 can be source of cervicogenic headache. Dysfunction of the neck and shoulder girdle muscles can be one of the main etiological factors responsible for cervicogenic headache. Patients with cervicogenic headache have a poor quality of life than that of patients with migraine and tension type headache. This is most common affected by zygapophyseal joints C2, C3, most common in patients with history of whiplash. Clinical presentation. Challenging to those clinically, but often includes unilateral Ramshawn or unilateral dominant headache. That is one side, exacerbated by neck movements or posture. It can be aggravated by the movements causing neck or sustained posture, sustaining in a particular posture, just a sitting posture, head down posture. It can be aggravated in that. Tenderness of the upper three cervical spine joints associated with neck pain or dysfunction. Definitive diagnosis made through selective nerve blocking through injection of specific sites. Compared to migraine headache, control groups, cervicogenic headache group patients tend to have increased tightness and trigger points in upper trapezius, levator scapulae, scaling, up, suboccipital extensors, splenius capitis, and sternocleidomastoidus. Weakness in the deep neck flexors, increased activity in the superficial flexors, atrophy in the suboccipital extensors, and so the deep muscle sleeve, which is important for active support of the cervical segments, becomes impaired. Impaired means it cannot work properly. Upper trapezius, sternocleidomastoid, splenies, levator scapulae, pectoralis major and minor, and short suboccipital extensors have been implicated. Trigger points have been reported to be present in patients with tension type headaches, migraines, cluster headaches. Differential diagnosis. How we can differentiate cervicogenic headache with other types of headache. The diagrams are provided here that can tell you easily the area of affection, the area of referral. We see according to we can differentiate in between these type of headache. Here is the differential diagnosis between three type of headache: cervicogenic headache, migraine, tension type headache. Mainly we can read about here is cervicogenic headache. Male is to female ratio is 50-50. Migraines and tension type headaches have difference in that. Lateralization, that is unilateral without side shift. Location, occipit, fronto-occipital and orbital. Frequency, Chronic and episodic frequency is chronic and episodic. Severity moderate to severe. Duration 1 hour to week. Pain character non-throbbing, non-lancinating. Pain usually starts in the neck. Triggers limited ROM, neck movement and postures. Pressure over C0 to C3. Associated symptoms usually absent or similar to migraine but milder. Decreased ROM. Outcome measures. Here are few scales by which we can analyze the level or the extent of disability and pain. Neck Disability Index, Headache Disability Index, the Northwick Park Questionnaire, Neck Pain and Disability Index, Numeric Pain Rating Scale, Pain Visual Analog Scale. The NPRS and SWAS we can use in any of the conditions related to pain. Above 4 scales are being used in the head and neck disability. No objective test set for cervicogenic headache condition is ruled in, and the treatment chosen based on the patient's subjective report of pain patterns. Diagnostic procedures, moreover, deal with the clinical presentation, how the patient presents with. Clinically, what are the chief complaints and disabilities and impairments the person is complaining and coming to us. Diagnostic nerve blocks are the other choice. Then we come to examination part. The diagnostic criteria as described by International Headache Society 2013. Pain in the neck and occiput that spreads to areas head, forehead, orbital region, temples, vertex, ears, usually unilateral. Any movement or a sustained static posture that relates to aggravation of pain. At least one of the following out of this: resistance or limitation of passive neck movement, changes in neck muscle counter, texture, tone, response to active and passive stretching and contraction, tenderness. Well, radiological examinations reveal moreover about movement abnormalities, flexion or extension, abnormal posture, or the previous historical conditions of the patient, that is related to fractures, congenital anomalies, bone tumors, rheumatoid arthritis, or other distinct pathologies. We can go through flexion rotation test. Here the link is provided. You can check it out. Then we come to medical management part. Medical management that deals with either the blockage of the senses which are going through the nerves or the CNS sensing through the nerves. That includes epidural steroid injections, particular in relation with the cervical spine, or nerve blocks, trigger point injections, radiofrequency thermal neurolysis. The surgical interventions include neurotomy, dorsal rhizotomy, microvascular decompression of nerve roots. Other medications that can be given in adjunct to this, tricyclic antidepressants that can be used at lower dosage than required for patients diagnosed with depression, muscle relaxants, and botulinum toxins in order to relax the muscle to get rid of the spasticity, spasm, spasm of the muscle. Physical therapy management. Here comes our thing. The vast of all, we have goals to achieve are mainly pain control, centralization, mobility, exercise, and conditioning. Mobility mainly concerns with cervical spine manipulation or mobilization. Strengthening exercises, deep neck flexors, upper quarter muscles, thoracic spine thrust manipulation and exercises. C1, C2 self-sustained natural apophyseal glide, that is SNAC. Further, we can add up to thoracic manipulation in seated position with CT manipulation, seated position with thoracic manipulation, re-educating craniocervical spine flexor muscles, in which we can do deep neck flexor exercises, re-education of craniocervical flexion movement, training the low-level endurance capacity of the deep neck flexors, retraining the cervical flexors of anti-gravity function in sitting position. Then comes extensors of the craniocervical spine, co-contraction of the neck flexors and extensors, retraining the strength of the superficial and deep flexor synergy, retraining the scapular muscles, in which scapular orientation in posture, training the endurance capacity of the scapular stabilizers, retraining the scapular control with arm movement and load. Then comes upper quarter strengthening exercises, re-education of posture, sensory motor training, trigger point therapy. Myofascial is related to mobility, strength, stability, postural exercises. In this, we can discuss about like trigger point therapy, in which we can use IASTM, instrument assisted soft tissue mobilization. Sensory motor training, re-education, we can give pressure biofeedback in this. We can use our hands for resistance. We can use patient's own hand for resistance, that is self. We can use therabands or consecutive loop belts. We can use further foam rollers and softballs can be used with this. Few more diagrams to include all the mobility exercises which we can do regularly. PT protocol should include these many aspects like mobility, strength, stability, co-contraction, retraining, sensory motor, biofeedback, that can be pressure biofeedback here, deep friction massage, transverse friction massage, ergonomic advices we can give. Few more diagrams to include soft tissue mobilization with softball and resisted exercises the patient can do by self with self resistance of his own hand. Neck mobility exercises, ROM exercises, cervical spine, extension, flexion, side flexion. Then chin tucks. Then comes the role of foam rollers. We can use in this way. The resources are International Headache Society and treatment-based classification approach to neck pain. This part is majorly taken from Cervicogenic Headache, an evidence update by Mark Shepard. At the end, I would like to say that the person can be taken as a whole, not just as the neck pain only, the treatment part. He can be treated with motion is lotion, we can remember, as correctly said by our dignitary from the field only. In the last, I would like to thank all of you. Thanks to Dr. Pradyut Koila sir. Thank you so much.